Well, good morning or good afternoon, depending on where you call home. Welcome to the NETEC COVID-19 webinar series. Today, our topic is patient proning, what it means for your patients and what it means for your team. We're going to get started today, but I want to make you aware of your ability to submit questions to the panel that is going to be introduced shortly. If you look at your settings on this Zoom webinar, you will see a window that says Q&A. And while there's also a chat function, we're going to ask that if you have questions, put them in the Q&A section. They're going to be collected. Near the end of this presentation, we're going to review those questions and see if we can provide you some answers. There's also a pretty cool function that lets you kind of give a thumbs up vote for questions that you see that you want to vote for to try and bring them to the top of the queue. And we'll address questions at the top of the queue in order and try to get you the best answers we can with the panel of experts that we have. I'm Alex Isaacoff. I'm an emergency medicine and EMS physician at Emory University. I've been a member of NETEC since inception, which is 2014, 2015. I'm the lead for the NETEC EMS activity. Next slide. So what we're going to do is in the next hour, we're going to cover proning. We're going to have Dr. Postelniku from New York talk about talk about proning during COVID-19, looking at this topic sort of in more in depth. Trish Tennell, colleague also at Bellevue, will talk about creating a team in a crisis. I'll briefly introduce transporting prone patients for the EMS community, but that will quickly be followed by Susan Wilcox, who will provide some greater detail about transport of patients in the out-of-hospital setting in a prone position, as well as use of proning in the emergency department. I will then review some NETEC resources for you that'll be available, and then we'll get into the Q&A session. So very quickly, an introduction about NETEC, which started in 2014, 2015 as a consequence of the Ebola crisis in West Africa, now evolving into the National Emerging Special Pathogens Training and Education Center, which has been working very hard from among three primary institutions, Emory University, University of Nebraska Medical Center, and New York Health and Hospitals, because they were the first hospitals to treat patients with Ebola virus disease and successfully discharge them from the hospital. Those were the academic health centers that first were engaged. Now, through a group of very engaged physicians, nurses, EMS personnel, planners and metrics developers and exercise and training development folks, emergency managers. There is a robust range of resources that are available through the National Emerging Special Pathogens Training and Education Center from way more than just those three institutions, but from a range of subject matter experts that come from the number of regional treatment centers that are engaged with NETEC on a regular basis. This is a range of the activities that that NETEC is involved in. They've been involved in developing preparedness metrics for treatment centers, assessment centers, and frontline healthcare facilities. There are tools that would allow any of those facilities to do a self-assessment. There are also ways to request an on-site assessment where teams will come and help do a readiness assessment of your facility. There are continuous offerings, either online or through webinars like you're engaged in today, or through in-person courses that are available through NETEC. And so the educational activities of NETEC, very robust. There's also opportunities for technical assistance. There's an online repository with a wealth of information as it relates to high consequence infectious diseases. You can find exercise templates there based on HCEP compliant models so that you can do drills and exercises locally. There's also an ability to request on-site technical assistance. And there's a very robust research network. The results of and the product of that work also being made available on an online repository. And there's a tremendous amount of work to develop policies, procedures, data capture tools, and other things to support the research enterprise as it relates to emerging pathogens. And with that, we're done with the introductory slides. I want to introduce my colleague, Radu Pastelnicu, who will do the deep dive of proning during the COVID-19 pandemic. Radu, it's all yours.
Thank you very much. All right, thank you, everyone. Welcome. So I just wanted to briefly talk about proning and discuss sort of the background to proning so everyone understands a little bit why we actually do it and the physiology behind it. So if we can go to the next slide, please. So the idea of proning is that really these patients, the patients that we're seeing right now, especially during the COVID pandemic, are very hypoxic and very, very sick, and they develop a very bizarre new form of ARDS. So really what we want to do is we want to figure out a way to sort of optimize oxygenation in these mechanically ventilated patients. And we know that they're severely hypoxic. So what are the best tools that we can use to do that aside from wonderful ventilator management? One way to do it is actually to prone them. So if you go to the next slide, please. So to fully understand proning, I think it's important to really understand the physiology behind it. So when a person is supine, the weight of the ventral lungs, heart, and the abdominal viscera increase the dorsal pleural pressures. And so this compression then reduces these transpulmonary pressures in the dorsal lung regions. And then there's also this increased mass of the ARDS, edematous ARDS as well, that reduces the regional ventilation of the dependent dorsal regions. All these gravitational gradients form a pressure and vascular pressure that then preferentially perfuses the regions and yields a region essentially of low ventilation and high perfusion, which to us manifests as hypoxia. So when we place a person in a prone position, what we're doing is we're reducing the pleural pressure gradient from these non-dependent to the dependent regions, in part through gravitational effects and conformational shape matching of the lung to the chest cavity. And as a result, then we see increased lung aeration, and then strain distribution becomes more homogeneous. So in this picture over here that we have over here in the figure on the left side in column 1, we see an isolated lung that is in the shape of a cone and the alveolar units, which are these circles within the cone. And this cone is essentially removed from the chest wall, and it illustrates how the unhindered lung contains more alveolar units in the dorsal regions than in the ventral region, and how gravitational pleural pressures, the gradient leads to a compression of the dependent segments. Now, in the second column, right in the middle of there, we see the effects of compressing the native conical shape of the lungs into this rigid chest wall, which is how it manifests in us. And while the patient is supine, the compressive effects of the gravity are magnified by the chest wall. They then compress the dorsal segments while expanding the ventral segments. And when the patient is then prone, as we see on the bottom over there, we see that the chest wall effects oppose gravimetric effects, and this leads to a more homogeneous aeration. And sort of this manifests sort of in the third column over here, where we see that experimental data on ARDS patients reveal that these patients, essentially the curve of pulmonary artery aeration varies as one moves along the lung's vertical axis. So there's this significant asymmetry in aeration and ventilation along the ventral and dorsal axis when supine, and a much more uniform gas to tissue ratio when prone. You can see the white arrows in the bottom right over there that show the recruitment of dependent regions, and then the black arrows that then reduce the regional hyperinflation in the well-aerated lungs. So they become much more symmetrical, and this is very beneficial essentially for our patients when they're prone. Go to the next slide, please. So some animal models have been carried out as well to sort of confirm this, and we see that the pulmonary perfusion along the lung height axis for both supine and prone patients. And here we see different bars, and each bar sort of represents the relative perfusion at that level of the lung versus if it's more dorsal or ventral. And we find that prone positioning, what it does is that actually it does not reduce the distribution of perfusion, but what it does actually is it markedly reduces the total shunt fraction. So this, again, this is something that helps helps with hypoxemia in these patients. Next slide, please. So what really manifested actually to prove that this physiology and what our understanding actually makes sense is the PROSERVA trial, which was one of the first trials that really showed benefit of proning. And this was this large multi-center unblinded RCT trial that looked at close to 500 patients with severe ARDS, and severe ARDS, as most of us know, is essentially a P2F of less than 150 and a FiO2 of greater than 6 and PEEP of 5. And these patients were getting 6 cc's per kilogram. So what they did is they had patients that were proned for 16 hours with good ventilatory management, so with a PEEP greater than 5 at 6 cc's per kilogram, versus patients that had just lung protective ventilation. So they compared the two groups. And if we can look at the next slide. What they found is that in the mortality in patients who were prone versus supine was significantly different. So at 28 days and at 90 days. At 28 days, about 16% in the prone group had died, while 33% in the supine group. And if we extrapolate that further to 90 days, what they found is that about 23.6% to 41% essentially was the difference between them. We also found that there's increased number of vent-free days in the patients when they were prone versus when they were supine. Next slide, please. So that's the data and the physiology behind explaining why proning is actually beneficial. And we've incorporated it into our protocols here as well at Bellevue. And while we've been using prone ventilation for patients previous to COVID-19, we had been using a bed that a special bed that some people may know, the rotor-prone bed, to put these patients in. But since then, we've developed a team that Trish will talk about in just a second. But we've also modified our protocol as well to include proning much, much earlier. So right now, the way we're treating our patients here is that we're starting with great lung protective ventilation, all the patients. So making sure that we have at least 4 to 6 cc's per kilogram, trying to minimize the effects of that, making sure that we don't overstep it and go higher to about 8 cc's or higher than that, maintaining our plateau pressures less than 30, our driving pressures less than 15, and having an adequate PEEP strategy. Now that's been sort of difficult because initial data out of Italy and some of China as well, when looking at the PEEP strategies, found that is actually higher PEEPs were beneficial, but then we've more recently found that PEEP, the lower PEEP, low to moderate PEEP, is actually much more beneficial to these patients. So it's sort of a modification of ARDSNet, the ARDSNet protocol. And we're also proning much, much earlier. So in general, if these patients have a P2F hovering around 150 or less, we then are proning them, and we have our prone team that helps prone all of these patients early. And we prone them in the afternoons around 3 o'clock and then supinate them in the morning. And if that doesn't help, we also have additional therapies. Obviously, we use paralytics much more liberally than before as well, because these patients are very dysynchronous with their ventilator, and paralytics have helped. But if not, INO, and now we also can do ECMO for these patients as well. So that's sort of a quick background, talking about prone ventilation, the physiology, and why it's important. And then I'm going to hand it off now to Trish, who's going to discuss about our wonderful prone team that we helped create.
Thanks, Radu, or Dr. Postal NICU. So my name is Trish Tennell, and I'm the Associate Director of Nursing at Bellevue H&H Bellevue Hospitals, and I'm also their nurse lead for their special pathogens team. So when we first started getting patients around the beginning of March, I sat down with Dr. Postal NICU and Dr. Alvear, and we talked about creating a proning team. And within 72 hours, we had proned our first patient. Next slide, please. So when you're creating a team in a crisis, you really need to look at all your options. You have to do a fast literature search and look at the different ways that people are proning and the benefits of proning. Also, you have to look at your staff resources. So I want you to look, that's part of our proning team right there. What we found with our staff resources is that nursing was already strained to the max, because as patients came into the ICU, the nurses were at almost a 1 to 4, 1 to 3 ratio. That's one nurse to 3 to 4 patients that were of ICU care. So what we did is we took inventory. We took inventory of what services were maybe not as busy as they usually are. And what we found was that elective surgery had went down, and that our ortho team was available, and our ortho team has already been proning patients in the OR. And then we had our anesthesia team, and the benefit of extra people coming in to help us. So we got those guys, and we wrote a protocol, and we started our team. We also had to look at what our equipment needs were. I will say at the very beginning, we were going to use the rotoprone bed, and we found out that it just was too labor intensive, and at the end we started to have 2 patients per ICU room, so it never would have fit. But then we looked at other equipment we'd need. You know, in a crisis, everything kind of runs out. So you have to look at how many pillows you're going to need, what you're going to need as far as flushes, syringes, linen. Remember, at your peak, we were at 105 ICU patients. So you really have to look at what you're going to need and what your resources are. And then you have to look at your PPE resources. At our peak, we were doing over 15 patients a day to be prone. And we have teams of 5. So that would have been 75 sets of PPE. And that's a lot of PPE because as you guys have heard and you've seen that PPE is a really valued commodity. So how could we decrease our PPE usage but keep up our infection control standards? And I'll talk a little bit about that. So with the large team, remember, you could burn a lot of PPE. Next slide, please. So then we went on to develop and create our protocol. So this is just a sign that we have hanging outside of the room. So if your patient's going to be prone, this gives a little bit of warning and times we're going to be there, what is expected of you with that protocol, and that's for supination and proning, okay, and gives people times and also reminds them to change their swimmer's positions Q4 hours. So again, when you're creating your protocol, you really do have to take into effect what you have, your equipment, your space, what staff you're going to be used. You have to practice your protocol because as I'm going to talk about in the next slide, it will change almost every time you go to prone somebody. And know what your limits are because sometimes you may not have everybody on the team and you're not able to prone everybody that they're requesting. And also make your players involved with your final protocol. So this is my advice. Please practice at least once, especially in a crisis. The first time I practiced our proning, we started to get a huge influx of patients and I didn't have any nursing staff or extra staff to help me do it. And I grabbed our COO, our chief operating officer, to come in the room with me and help me prone our mannequin just to make sure that I had the process right. This really helped because it helped us work out some kinks. The second time we proned, which was almost less than 72 hours, we proned a patient and it was Dr. Postelnicu and Dr. Alveolar. Oh my God, Alvear, sorry. I've got Avioli on the mind. And one of the nurses. And we were able to prone this, and this took us about 30 minutes to prone our first patient. But then we were able to sit down afterwards, the 3 of us, have a good debrief and go over how our protocol would change. And just so you guys know, today that protocol still changes. And this protocol changes as the patients change. We're now proning people with trachs, bedside dialysis, hemodialysis and continuous renal replacement therapy, and peritoneal dialysis. And just as we're getting our numbers, we've kept at least 4 people off of ECMO, which we're very proud of. And remember that as your team changes and staff changes, you get fresh eyes on your protocol and your procedures. And that really does help with changing and concentrating your protocol. Next slide, please. One of the things I want to talk to you about a little bit is equipment on the go. When in a crisis, all your patients, like we converted 3 different places into ICUs in various parts of the hospital. So we had our mobile equipment with us, and this had everything we would need to prone or supine a patient. Nobody likes to wait on a flat sheet to come inside the room, but we had this mobile equipment with us. It went with us everywhere. It made it run smoothly. And again, this equipment list was adjusted as we moved on, okay? What we did was we kept this outside the room, the cart outside the room, so it remained clean, and then we just pass in whatever the staff needed inside the room on the proning team. And also, you need to make sure you have enough. All right, next slide, please. You know, I'm going to talk just a little bit about PPE implications and conservation methods. And our spotter role. So we kind of did a dual role for a spotter, and our spotter was also in charge of the equipment and making sure that the team had everything they needed. But we were also there to watch people don and doff, to make sure people did hand hygiene between patients, to make sure that they didn't become contaminated during the procedure, or as you guys all know, that PPE will change during the course of your COVID hospitalizations. You get new PPE, you get donated PPE, PPE comes in, it's just a little bit different. So you really want to watch, because some of these can get ripped or they don't cover as much, so you really need a spotter there. Again, I talked about conservation methods. So what we learned, and again, this is evolving, was that if we were doing all the patients on the same floor, that the team, when they were inside the room, would hand hygiene, and the majority of our team wears 2 pairs of gloves. They'd hand hygiene, take off their first pair of gloves, exit the room, hand hygiene again, put on the second pair of gloves, and they would go straight into the next patient's room. So that really helped us with PPE conservation. Imagine we brought it down to 10 sets of PPE with just glove changes, as opposed to 75 sets of PPE. We basically saved 65 sets of PPE, and that also helped people that needed to go into the room 65 other times that they would be able. So it really helped conserve on that. If we were going off the unit into our other units, our 2 satellite ICUs and our emergency ward, then we would doff PPE. We never left the unit with PPE that we had worn in the patient's room. We never took an elevator ride, anything, except we did keep our respiratory and eye protection on when we did that. But we really tried to conserve. The spotter always reminded of hand hygiene, to clean off areas if they looked contaminated before the team went to the space, and also watch them doffing. And I will tell you, as time goes on, and I think that we've all noticed it, you really need this spotter there, because sometimes people come a little comfortable and a little complacent with their PPE standards, and that is really an important role. They also are able to monitor the team as they move from one patient room to another. They're able to look at the environment to make sure that they just go directly in the room, no stop and chatting. And it also, again, very important, reinforces the doffing process. Next slide, please. So I'm going to talk to you a little bit about sustainability. All right. Now, sustainability, it's very important for us, because we did not have a proning team before we came into the COVID-19 crisis. So now we're moving on from our team, because as the admissions for COVID go down, and people start coming in for more elective surgeries, and our team because our team is mostly orthopedic surgeons and anesthesiologists. Now we're going to convert it into a sustainable team once they've left. So now we're going to add into our respiratory therapists. We're going to go into our floor physicians a little bit more, and we're adding members of our nursing staff to help with it. And you know that this could vary from day to day, because staffing numbers do change. But again, you have to look at your resources. If you have a skincare team or a turning team, they could help you with your proning. But you also have to remember, you want this to go 7 days a week. Are they able to cover the weekends? You need to look at the benefits of proning also. A proning team is sometimes more cost effective than running the bed. Length of stay could decrease if early proning is initiated, and also reinforces skin care in mobile patients. And I'd also like to say this has really brought a lot of teamwork and camaraderie, brought us to know different departments in the hospital, helped our nursing staff, helped our physician staff, and our ancillary staff. Everybody's just there to take care of the patient, because we want to make sure that all our patients get the best care that they deserve. Next slide, please. And now I'd like to introduce Alex, and he's going to talk about transporting when prone.
Thanks, Trish. I've already made my introduction, so let's go to the next slide. So the question that had come up, even in some other forums, when there was discussion about using patient proning for COVID-19 patients, was, to the EMS community broadly, well, do you transport patients in a prone position? And, at least in the forums where that question was asked, it didn't appear that there was a whole lot of experience with it, at least, again, in the forums where the question was asked. So it actually prompted, in anticipation of this presentation, just a brief literature search to see what the experience was out there and what people had written about. And so this is an example of a paper that was written in Pre-Hospital Emergency Care, published in 2016. By Della Volpe and colleagues, transported a mechanically ventilated patient in the prone position. And it's a pretty modest case series, 7 patients that were transported in a prone position, 6 of them by helicopter, 1 of them by ground ambulance. And some of the characteristics of these transports were that they all had an FiO2 of 100%. The median PEEP settings were 16, range 14 to 20. The weight range of the patients were 58 to 131 kilos, so quite a broad range. And that patient demonstrated that, at least in this short case series, that someone with a high BMI could be transported safely. The median transport time was 36 minutes, but the range went out to as far as 2 hours. And in this case series, 7 patients were transported prone. Again, 6 by helicopter and 1 by ground EMS, with no deaths or major incidents. Now, the way they conducted their operations, this was all a single center case series, is in every one of these cases, the patients were already prone in a community intensive care unit, and they were being transferred to a tertiary care center for any number of reasons, including the possibility that these patients were looking for an ECMO consultation. But the patients were already prone in the ICU prior to transport. And it was in the patient's interest that they remain prone for that transport because of all the physiologic benefits that Radu had described earlier. So in each one of these cases, medical control was consulted prior to the transport, just to review the patient's circumstances, the patient's condition, and then make sure there really weren't any contraindications to proceeding with transport in the prone position. As is often true for EMS teams that are transporting patients from one ICU to another, or transporting critical care patients that are on a vent, once the patient's transferred onto the transport stretcher, or maybe even once the patient is transferred to the transport ventilator, it's always good to ensure that the patient's going to tolerate those vent settings. And so in every case, they had a brief trial to ensure that the patient could tolerate coming off the hospital ventilator and onto the transport ventilator. And then maybe more importantly, also based on how the patient was positioned on a transport stretcher, ensure that the patients were oxygenating well and were, they were able to optimize their physiologic parameters. In this case, even though patients on the hospital vent were in different ventilation modes, the transport team here elected to transport all patients in continuous mandatory ventilation mode, or CMV mode, which was facilitated clearly because the patients were getting sedation and all had neuromuscular blockade on board. Next slide. So there were some observations, and just to be clear on that first point, there were some observations among the patients that were transported. One is that one of the patients that was noted prior to transport had nasal pressure ulceration. And that's one of the potential complications for patients being in a prone position. For me, for the EMS community, it means that the teams that are going to do these interfacility transports just should document well what the condition of the patient was prior to taking them, into their helicopter or ambulance, just so that there's no concern that whatever might be noted on receipt of the patient at the receiving facility, that it existed prior to EMS engaging and managing the patient. Another observation, and this is pretty well recognized among prone patients, is just because of their position and gravity, a lot of these patients, especially if they've been prone for some period of time, will have facial and periorbital edema. I mean, so much so that in some cases, the lids are so swollen, the patient wouldn't be able to open their eyes if they wanted to. But I think it's important for EMS personnel to anticipate that facial and periorbital edema. which may also potentially complicate reintubation if the patient was inadvertently extubated. Another note was that there was a fair bit of secretions draining from the ET tube in these prone patients, which actually makes sense. In a prone position, patients' larger airways are actually kind of oriented in a way that would allow gravity to draw those secretions more easily. And actually, as it turns out, in the observed outcomes from this brief case series, 2 patients actually required frequent change of CO2 capnography lines because they were getting fouled by the secretions that were coming from the ET tube. Overall, there were no deaths, no episodes of hypotension, no endotracheal tube or line dislodgement in this case series. So this demonstrated that it could be done safely with, this was a paramedic nurse team, no physicians on board this transport, but could be done safely by a typical paramedic nurse team that was properly educated and trained to transport patients in this position. Next slide. This is another recent case report published in 2018. It's in the Air Medical Journal. What makes it maybe a nice read is it does describe some of the physiologic benefits for proning. It gives a fair bit of background. It also identifies some additional complications associated with proning in general, not necessarily because of the transport of the patient, but some of the complications associated with proning also inform how the patient needs to be positioned for transport, meaning that there is risk for pressure ulcerations. Depending on how limbs are positioned, there's risk for neurovascular compression and neuropraxias or maybe transient ischemia as a consequence of that. There's often notations about ocular injuries because the patient's in a prone position. And so it's often recommended that the patient's eyes be lubricated and taped shut to prevent corneal injury. And of course, there's always that risk for displacement of the endotracheal tube. And so using a commercial tube holder is a good recommendation in transporting a patient that's prone. Another consideration that we would all have, whether it's in the hospital setting or during the transport phase on an interfacility transport, is what to do with a patient that goes into cardiac arrest while being transported prone. There's concern that if by trying to flip them back into a supine position, that you're going to risk dislodging the ET tube or dislodging some critical IV access or lines. And actually, there's in this case report, they actually recommend CPR in a prone position and application of defibrillation pads either in the AP or anterior lateral position. We'll address that very briefly in the next slide as well. But in any case, there's need for extensive simulation-based training sessions to, that was the opinions of the authors, in order to do this safely. Next slide. So just to highlight a couple other publications that were present similar findings. Another description of transport in a 2003 article in Anesthesia and Intensive Care. Actually, there's an early report from 2002 that actually was looking at safe interfacility ground transports of critically ill patients with ARDS. And some subset of them, some 14 of them actually were transported in the prone position. Now, what was different about that study in comparison with the first case series that we discussed is that this was a European model, and so there were physicians and a larger transport team than you might typically find in our air ambulance services here in the United States, which are usually, 2-person teams. They also had a hospital ventilator on their ground transport service. And of course, we've already discussed the use of transport ventilators under these circumstances. But it's a nice study for reference. And then we said we'd come back to prone CPR. Most of you may know that the AHA, together with its partners, published earlier this month, earlier in April, some interim guidance for advanced life support for COVID-19 patients. And they acknowledge that patients may be in a prone position because of the improved oxygenation associated with that prone position in patients with severe respiratory embarrassment. And they recommended that while the effectiveness of prone CPR isn't really well known, they still recommended doing CPR in the prone position to avoid dislodgement of airway and equipment disconnections. And they're recommending a hands-on position, hands in the standard position over the T7 to T10 vertebral bodies. And so for somebody that's prone, maybe the best way to estimate that would be to kind of feel for their scapula and down, in the inferior portion or the lower tip of the scapula. That would roughly be in line with the T7, T10 vertebral bodies. And so that would be a good place for hand placement. And the reference from the AHA guidance that was recently published actually is a 2003 case series, very short, small case series, I think just 6 patients, that looked at maintaining mean arterial pressure and SBP with patients getting compressions in the prone position. And those case series actually were, I would say, favorable for doing CPR in the prone position. And in that paper, they were also referencing that, there are many operative cases that require a patient to be prone on the OR table, similarly endotracheally intubated and with support lines. And there were also some short case series reported and referenced in that paper where patients that went into cardiac arrest in the operating room in the prone position were successfully resuscitated, neurologically intact after receiving CPR in this manner. Next slide. All right, with that, I want to turn it over to my colleague, Susan Wilcox from Mass General. She's going to talk about proning in the ED and is going to go into some more detail about putting patients in the prone position in the out-of-hospital setting.
Great, thank you so much. Next slide, please. So I'm going to start off by talking a little bit about the data behind doing proning, self-proning in the emergency department. And to be very clear, when we're talking about self-proning, what we're talking about here are patients who are not intubated. So these are patients who are still awake and they're coming in with hypoxemia. I have to apologize to all of you. They just started doing construction work on the building right next to mine. So I'm so sorry for that terrible humming noise. I don't know how to make it go away. My apologies. So for this study, it was a really nicely done study out of New York, where they looked at 50 consecutive adult patients who came into the emergency department with hypoxemia, which they defined as being less than 90%. And if they did not respond to supplemental oxygen, they were included in the study. And what they found was that these patients came in very hypoxemic. They had a mean SpO2 of 75% if they showed up without oxygen. And if they were wearing oxygen, say like they came via EMS, they had a mean SpO2 of 82, or median, of 82. And they only improved about 84% on their SpO2 with the provision of oxygen in the emergency department. Next slide, please. So what they did is they took these patients and they had them roll over into the prone position. And you can see there that their median SpO2 shot up. It went from 84% up to 94% with just the change in position. And this was after just 5 minutes. So very quick response. They followed these patients throughout their hospitalization. And over the first 24 hours, 13 of them ended up getting intubated. But that means that about 75% of them did not. The patients who failed usually failed pretty quickly. You can see there about half of them, 7 of them, failed within the first hour in the emergency department and needed to be intubated. So, that's actually fairly reassuring. The people who are going to do well often will, or who not do well, will actually show themselves pretty quickly in time. Another 5 ended up being intubated at some point during their hospitalization, another 3 between 24 and 48 hours, and then 2 after 72 hours. But the takeaway from this small study is that it does appear to be reassuring. It's a fairly low risk intervention, and it does seem that for some of these patients who come in with pretty impressive hypoxemia, we can buy them some time, and many of them will improve, and they won't ever get intubated. Next slide, please. So what we're doing in our emergency department is very similar. We have this guideline that we've written up for self-proning in our emergency department. So it's similar to patients who come in with hypoxemia, either on supplemental, if they have some dyspnea despite supplemental oxygen, or if they get up and they're moving around and then they go into a significant respiratory distress, we can use this as a rescue therapy. The contraindications are people who are not able to follow commands. They're not people who aren't able to work with the nurses and listen to instructions. People who are not able to turn themselves over in bed, because we can't have a scenario where we're risking patient safety. We don't want the patient to be utterly dependent upon the nurses to move them. They have to be mobile enough to flip themselves should they have the need to change position. So if they have hemodynamic lability, if the heart rate's too high, the blood pressure is too low, or if somebody needs immediate intubation, what we don't want to do is have somebody who comes in who is clearly in extremis, and then we waste time or let them deteriorate by doing this if it's a clear-cut case of the patient needing to be intubated. Next slide, please. So here's an example of a clinical scenario that we used self-proning with. So this was a man who came in. You can see there his oxygen level is fine. He's got a SAT of 97%. He was on a non-rebreather, but he was doing okay. But he's very tachypnic. He was one of those patients that you look at from the doorway, and he was clearly in distress. He was working very hard to breathe. We turned him and we proned him, and he, within 7 minutes, you can see that his respiratory rate came down from 35 to 28, his heart rate came down, his blood pressure came down, and his oxygen level was stable. So it's, it was a very nice example of how self-proning worked nicely in our ED. This gentleman ended up being admitted for about 5 days, and he never got intubated and was able to go home and avoided an endotracheal tube. Next slide, please. Now, conversely, I have another example. This was a woman who came in her mid-80s who was also in extremis. You can see that her respiratory rate was 43. And if you look there at her 12 lead on the monitor, you can see the strain on her myocardium from this profound hypoxemia. She was in her 80s. She was not very mobile.
Yeah, Susan, you just came back. You appeared to drop off, but I think you're back.
I'm so sorry. Okay, so we did not end up proning this patient because she was too far in extremis. She is not a good candidate for self-proning. Next slide, please. So the benefit there is clear, right? That we want to avoid intubation. And so this is proning is fantastic if we're able to use it in that way. The risk of using this in the out-of-hospital setting is that if we have a patient who is proned and we have any sort of complications, so lose the airway, they decompensate, anything like that, then you can't get to the airway, you can't take care of them as your team normally would. And then, of course, there's the issue of safety. You want to make sure that your patient is well secured in the vehicle, and our usual ways of securing patients and providing safety expect them to be in the supine position. So that definitely requires some modification. Next slide, please. So we do have a protocol for this at the critical care transport team that I work for. And so we have a non-intubated out-of-hospital proning protocol as relayed here. We specifically do not initiate prone positioning for non-intubated patients for transport because of the worry that if we do so and then we determine that they need to be intubated, now we've lost some time. We're going to have the risk of having worsening hypoxemia and the worst possible outcomes when we intubate them, that they could crash. And we also say that patients have to be managed by the sending facility while prone for a little while. We want to make sure that they are reasonably stable in the prone position, kind of like what Alex was getting at, that we want to make sure that they've been prone and they're doing well with it before we transport them prone. The suitability is that they have to have minimal dyspnea. They can't be in extremis. They can't have altered mental status, especially not from hypercapnic respiratory failure leading to them being altered. And we have to make the assessment that they'd be unlikely to be a difficult intubation if, heaven forbid, en route, we needed to manage their airways. Next slide, please. This is a little bit different than our intubated protocol. We do have this now. It was new. As Alex was mentioning, we in our critical care transport group have not historically transported patients prone, but with COVID-19, we recently changed our protocols and have now written this intubated patient protocol for transporting the interfacility patient. One of the things that we do is we're very clear about the risks of the transport. And we have a phone call on a recorded line that includes the sending doc, the receiving doc, and then our medical control physician as well. Everyone on the line saying that they all understand that this is not an ideal situation and there are definitely risks, but we determine that the benefit of the transport outweighs those risks. As we were discussing earlier, as Trish was pointing out, we have to have a team to do this. You have to have a lot of people to make sure that you're moving the patient safely. We're not even proning these people. We're just moving them from bed to stretcher or vice versa. And so we want to make sure that we have plenty of people there to move them, to secure their tubes, lines, and drains, especially the endotracheal tube, and do everything safely. The patients have to be well sedated and they need to have neuromuscular blockade on board. We use a slide board, we go halfway, and then we stop. We want to look at all the tubes, lines, and drains and make sure that everything is still safe before completing the move all the way over onto the stretcher or from the stretcher onto the bed. And we're very fastidious about the body position. As we've heard earlier today, the body position can really make a difference. As Alex was saying, it can lead to injury. And even though many of these transports are short, we don't want to have any sort of injury to the face or any other pressure source. Next slide, please. So this is just an illustration, of course, using the dummy to show what a prone transport would look like. And we have these in our protocol so that all of our team members can see what we're aiming for here. We want to make sure that the face is protected, thinking about the pressure points there, that the breasts are well supported for female patients and male external genitalia are all well supported. The patellas and the toes, anything that could be a pressure point is supported and being adequately padded so that they don't develop any pressure sores en route. Next slide, please. So because we are transporting these patients in the prone position, we have to be thinking about our contingency plans. And we have this written into our protocols. We talk about the flip method. So putting a sheet all the way around the patient, kind of like a burrito. We want to wrap them up and pull the sheet taut. And then if we need to flip the patient, then we can use the sheet as an instrument to do so. Next slide, please.
Susan, we might have lost you again.
Oh my gosh.
Discussion of the flip. Here you go.
Yeah. So yes. So that's just all I was saying. That we want to make sure that we have some sort of contingency plan if the patient were to become unstable and we needed to manage the patient's airway en route. So next slide, please. So with that, I'll turn it back over to Alex.
Great. Thank you so much. So we're just going to do a very quick recap on NETEC resources. And particular to this particular presentation. You may get off this call or this webinar and say, boy, I wish I'd asked that group some questions. And you can still send us questions. If you send your questions to info@netec.org, we'll answer questions about patient proning. You can actually send any question you want to info@netec.org. I mean, so long as it's about emerging infectious disease and how to manage patients, and you'll get a response back from the NETEC SMEs. You can also submit a technical assistance request, as was described before, where you might be looking for some particular information or may even be looking for someone to come and help you in person work through some issues or problems. So much as we can support that with travel restrictions now and and physical distancing, we certainly will. Zoom has become a remarkable technology. And so submit your technical assistance requests at netec.org. Next slide. So this brings us to our Q&A session. And I am going to look at the Q&A box here and see if there are any unanswered questions. As you might note, when you go to that section, you'll see some questions that our colleagues have been answering. I'll just maybe quickly review them. There will be copies of slides after the presentation that are available through netec.org, not just the slides, but a recording of this webinar as well. And then, of course, questions about proning non-ICU patients as a consideration. Susan, it looks like you weighed in a bit on the proning of non-ICU patients. Did you want to comment on that a little bit more?
Yeah, so for those who didn't see the question, there was a question about proning patients who are not going to the ICU. In our emergency department, we have been able to avoid some ICU admissions by self-proning the patients. And then for some of the patients that we've proned, even if they've had a good response, they've continued to need the proning, and our floors have been willing to take them. We have patients who deteriorate on the floor, and one of the first maneuvers they're using for floor teams is to do the awake proning or the self-proning.
Great, thanks, Susan.
Yeah, and to chip in with actually Bellevue, we're doing the exact same thing here, where we're actually having patients self-prone, and when we get the initial critical care consults for these patients, we actually have them self-prone. The medicine teams have also been asking patients to self-prone. So actually, if you walk around the ward, you actually see a lot of patients who are self-proning, even sometimes with non-invasive ventilation as well.
Great, thanks, Radu. Another question that came up was whether or not hospital teams have considered involving PT staff for the proning of these patients. And Jill Morgan actually replied, and Jill, I don't know if you can come on, but to indicate that that would be a great use of that resource. Trish, any additional comments about use of physical therapists maybe on the teams that are flipping patients?
Yes, I was going to answer this, but my computer illiteracy took over. But you know what I wanted to say is that I think PT would be great to be involved in our proning team. But what we found is our PT was still so busy with our in-house rehab of our COVID patients that it was a resource that was already being used. So they weren't available at the time, but they'd be a great asset to any team. It's just that they were still working with our rehab patients, and they weren't available for us. But I think they're amazing because they really know body mechanics and how to move patients.
Yeah, very good. Who wants to comment on central lines? Maybe Radu, since you're in the ICU, central lines and line sites on these patients that are being prone.
I mean, we just make sure that every single one of them, that they're adequately padded, and that they're either, if they're new lines, that they're well secured. If they're old lines, they're definitely well secured. And then we just keep special precautions when we look at them when the patients are getting prone to make sure that there's no dislodgement. We haven't had any issues with the lines being dislodged.
Great.
And I just want to tag on to Radu's thing about lines. Most of our IV pumps are outside the room, and the patients are inside. So we have a lot of extended tubing and a lot of tubing going, you know, an extra 6 or 7 feet. So, you know, that really helps when you get this extension tubing on, and, you know, you're able to monitor that with your patient.
Great. Thanks, Trish. There are a couple of open questions here. There's a question about sitting patients in a leaning forward position in an ambulance. I'm trying to interpret that question. Maybe there are persons asking that to offer that as an alternate approach to patient proning. I'm not sure that that's been studied well to try and replicate the physiology of patient proning. We clearly know there's some value in patients leaning forward that are having, you know, respiratory distress and weakness of their respiratory muscles. But Susan, anything further from you on sitting patients forward if the question is trying to replicate the physiology of patients in a prone position?
So, we certainly will transport a patient on occasion sitting bolt upright at about 90 degrees. But that's about as far as we're able to get them sitting up and make sure that they're still secured pretty safely.
Mm-hmm, right. Yeah, and it looks like the listener actually tried to clarify the question by, asking if you could put a patient in a very forward-leaning position, whether that would be helpful or in any ways equivalent to being prone. I simply don't know the answer to that question. So anyone else on the call want to try and field that?
This is Paul Bittinger. I would say we have seen some anecdotal success with lateral recumbent position, or lateral decute, excuse me, that if you have people lying on their side who cannot tolerate full prone, we have seen some physiologic improvement with that, and there is obviously some physiologic reason to believe that you're getting closer to decreasing the shunt, as Radu was talking through before.
Sure. Thank you, Paul. There is a question, a listener asking if in the pre-hospital setting, are there any conditions other than COVID-19 that would benefit from a patient being in a prone position? And Jill Morgan rightly responds that being in a prone position for some patients actually has been regarded as deleterious. So if you think about excited delirium and someone needing to be restrained, there's always concern about them being in a prone position. But any other comments on patients being transported prone, absent signs and symptoms of COVID or respiratory failure from COVID? I can say that's it's not a common means of transporting patients, and nothing for me immediately comes to mind.
And
Susan,
to
anything
add
to
in on
add?
that too,
Radu, go ahead. I'm sorry.
No, to add in on that, it's before pre-COVID days, we had many patients who were ARDS patients or who had really bad pneumonias, and we never really prone them as aggressively. I think it's the reason we're doing it with COVID patients is that we're seeing that they have this very interesting physiology to them, and that the proning actually does is very significantly beneficial even earlier on. Granted, we haven't really studied the data in non-COVID patients as well, so we don't really know, if it would have any impact on a very bad pneumonia or viral pneumonia before they come to the ICU or before they even come to the hospital in the ambulance. But I think it's the dangers of possibly proning someone who is not this pathophysiology may be higher than the benefits. So I think, especially in the pre-hospital setting, I think transporting the patient to an emergency room to get evaluated appropriately and figure out actually what is wrong with them if it's not COVID, especially let's take our COVID hats off and that maybe there's something else that's occurring. I think it's appropriate to just make sure that we don't increase the risk of potential harm in the outpatient setting or in the out of hospital setting. And then once in the hospital, we can evaluate further.
Yeah, for sure. Radu, and actually, I appreciate you chiming in on that because, I think maybe much of the interest in proning patients with COVID has come from experience with proning of patients with ARDS. And so I think for that listener that asked that question, there is the evidence of patient benefit in acute respiratory distress syndrome or ARDS. And so I'm glad you chimed in on that. I would have been embarrassed to have not mentioned that in this context. Is there anything that the panelists want to close out on in terms of final thoughts as we've come basically to the end of our webinar?
First, I just want to say thank you to everybody, but I just want to add just one more thing about sustainability. If you look at people that maybe have bad pressure ulcers or things like that, that's another reason to use your proning team, that you may be able to take them off some of these pressure points to allow them to heal a little bit. So that's another good selling point to your facility to implement your proning team.
Great. Thanks, Trish. Any other closing thoughts from any of the other panelists? No pressure, no requirement. Just want to give you the opportunity. If not, then the slide that's up now is just a reminder that at the completion of the webinar, you'll be directed to a webinar online evaluation. Very important for us to hear how to, well, one, what you thought about it, but two, how to improve it for future webinars. And then don't forget to get your 5-digit code, which will allow you to get your certificate to prove to anybody who wants to know that you've gotten this 1 hour of CME or CNE. And again, those certificates are available for up to 60 days from today. Next slide, please. All right, just a few URLs. Point your attention to youtube.com / the NETEC for NETEC skills videos that are out there. Also the NETEC e-learning center at courses.netec.org. And you can see there's quite a number of different URLs. Don't forget the info@netec.org email in case you have any questions about today's webinar or any questions about patients with serious emerging pathogens and how to best manage them. But if you can't remember any other URL, just remember netec.org. That's netec.org. And you can then navigate to all the resources that are there. You can jump in on Twitter and Facebook and other social media platforms as well. And so with that, I'm not sure if there's a next slide. There is. With that, I want to thank you all for taking an hour out of your lives to spend it with us. I know that this group was really pleased to come together, to put these slides together, to try and disseminate the education and best available evidence associated with proning patients during this COVID-19 pandemic. We hope to see you at the next webinar. Thanks so much for attending, and thanks to all who participated, both presenters and listeners. Bye all.